Bismillah ar-Rahman ar-Rahim. We'll talk today about the perioperative care. So inshallah we'll talk in a different way. So the preoperative care is everything related to the patient journey in the hospital away from the operative theater, like the operative techniques. So it's a preoperative, what's going intraoperative away from the operative details, and postoperative until discharge of the patient. So I just copied one of the programs that is adopted by Toronto Sick Kids Hospital, and they resemble the patient journey in the hospital like the flight plan model. They call it the NASA model, and they give and this is also the way how they do their performance rounds and M&M. They resemble like the whole patient journey, like this flight plan. So they consider, like as you see here, this is the journey from the patient entering the hospital till the time going home. And they have some definitions which called the threat and error models to detect any errors, and also to how to control the errors, and how to also do the performance rounds and document all of this. So they give, as we all know, the perioperative care, the preoperative preparations, the patient's data, the patient physical examination, the patient history, the patient file. This is all done in the system of any hospital. But how to deal with this as like we are surgeons? So they give some definitions, which like it's called, something is called the threats and errors, and something is called unintended state. This is the threat, error, or unintended. The threat, they give it like any. This is like the risk factors, like the preoperative risk factors. This is any non-ideal aspect that happens to the patient. The threats, the risk factors. This could be the morphology, risk factors, comorbidities, even the threats of any equipment problem, any external factors, any operational stressors, latent cultures, like any threat that might cause any suboptimal result of the patient journey. This is like preoperative risk factors. Then if the patient goes inside the hospital, and like, as you see this curve here, they resemble this, the risk, when they plot the risk with the stay with time in the hospital, the risk increases with time stay in the hospital. And you see the risk goes, the peak goes when the patient in the OR, and goes to the first day post-operative, and decrease until the discharge, was almost, there is no risk. To the threat, they call it like, this is the any risk factors that might lead to a suboptimal result. And this is, as I mentioned, maybe morphology, like not all cases together the same. Like if you have, for example, a TOF case, not all TOF the same. You have some, like if you have, say, for example, TOF case, you have a TOF case, you are resident, you are presenting a TOF case. Then not every TOF the same. If any TOF was coronary anomalies, with multiple VSDs, with any other comorbidities, lung issues, syndromes, or any problems in the labs. So, or also any external factors that may cause this. This is threat, that you have to be careful of these threats, risk factors that might alter the flight plan. And also, everybody is welcome to have any interruption or any question. Hello, Abdul Malik?
Yes, doctor.
Yeah, I want everybody to feel free anytime. Like we make it like not a real formal official, like we say, we make it like more friendly. Anyone want to stop, and if anything not clear, or we want to make it, because I really like this model, because this is the model how they make the as I will show you later, how they make it, as they use it in their performance rounds, and how they detect the errors and how to make it. So the threats, this is the risk factors preoperative, and in the errors could happen, which is E here, the red one, the E, these errors. This error may be an action or inaction. that might lead to also suboptimal unexpected result, or also a deviation from more deviation, or decrease the safety margin of the patient journey in the hospital or the operation. So this error could be something like deviation from the standard path. Any injury happens, mistake, procedural mistake, or any communication problems, dose errors, counts, or also or suboptimal execution of a task. Like you have a case, redo case, and you go intraoperative and bleeding happens, for example. This is called error. This could happen. This is procedural, or maybe also decision error, judgmental, like this is judgment error that might cause also a problem or deviation from the original plan. All of this at the end can cause unintended state of the operation. And this unintended state, if not the error could happen, but if not properly and optimally dealt with, can cause a propagating cycles of errors. So also decrease more the safety margin. Like, let us give example about the theoretical issue. Like we have a case, for example, problem in the diagnosis, like you find the diagnosis in the OR, something like you have a tough case, then in the OR, you discover there is a coronary crossing, the RVOT. This is a judgmental error that can cause unintended state of errors or propagate cycle of errors. No problem could happen, this judgmental error, but also if it's dealt with properly on time, like if it is diagnosed intraoperative, then the change of plan, like do the proper management, like putting RV to be a conduit. But the problem, if this propagating cycles of errors, like if we cut this one, we just go and see without even revising the anatomy. So this is a problem of, can cause that propagating cycle of errors, that we can go open the RVOT, then the problem is having this errors, propagated cycle of errors, which makes the problem less. And even like this next slide, and this is the way how they do their performance round. If you go at the same, this one, this is the patient journey inside the hospital. This is a preoperative. They went in OR. They have cross-clamp time. This is a VSD case. Then they have a cross-clamp time 64. But you know, preoperative, they have an error, carotid puncture during CVL. Then after bypass, they have residual VSD. This is another error, but should be dealt with on time to minimize the complication that causes this errors from propagations. Anyway, this will go now. The patterns of recovery. Now, if the patient comes out of the OR and goes to the ICU, we'll talk now more post-operative now, because you know what I mentioned in the preoperative, that everything, all preoperative data can determine the outcome and can cause and also can cause this deviation from the standard plan of the surgery. Then now the patient comes out. We're talking now more pediatric, like this is an ICU. This is how we manage the patients in the post-operative. First of all, knowing everything that happens in the OR, determine that everything happens in the OR, in the post-operative. Like this also, the total cross-clamp time, the aortic cross-clamp time, if there is deep hypothermia, circulatory arrest, or on the patient done only on bypass without cross-clamp, everything in this matters. And also the lowest temperature and the timing of, like if you are expecting to have a patient with a very long cross-clamp time and very low, like the deep hypothermic circulatory arrest is completely different patient from patient just smooth, quick aortic cross-clamp time. As you all know, increased myocardial ischemic time will increase a myocardial dysfunction, and also having the first night prolonged low cardiac output. Also, the total bypass time, if it is really long, it affects also It will increase the capillary leak, which is a generalized edema in the patient, and ascites, and with fluid retention. It's also pulmonary interstitial edema that might need prolonged ventilation. Then this is more, and this is a cutoff probably like 2 to 3 hours, this bypass time. More than that is really too long and might affect the post-operative care of the patient. And also, if you have cases that needs arch repair, like cases of arch repair or interruption or hyplas you need prolonged deep hypothermic circulatory arrest. Also, there is a potential risk of increased seizures in the first night. And also, you should avoid the CNS insults by hyperventilation, fever, or hypoxia, or low cardiac output. All of this can cause more secondary CNS insults. So this, and also the most important factor that we need to know about the immediate post-operative course for neonates and infants undergoing repair of biventricular heart disease with cardiopulmonary bypass, predictable drop in cardiac index with considerable increase in systemic vascular resistance and pulmonary vascular resistance over the first 6 to 18 hours after removal of the aortic coronary lamp. This is a very important piece of information. I want to show you here this pattern here, this one. The first night of the patient, the cardiac output drops significantly at the time with increase, maximum increase of pulmonary vascular resistance and systemic vascular resistance post-operative. And this is reaches the maximum around 12 hours of operation. The first like 12 hours. Usually it's midnight of the first night. When you have a neonate case or a small baby, usually when they come out of OR, you know, it's a little bit stable, but with time, the pulmonary vascular resistance and systemic vascular resistance increases till almost over the midnight. And also when everybody's like almost feel like everything is fine, is sleeping, then problems happens usually in the midnight, because it is explained by the maximum increase of pulmonary vascular resistance and systemic vascular resistance, which is coinciding with the lowest cardiac output. That's why this time the proper inotropic support and take care of the patient as a whole is very important with this one. So we go back. This is a low cardiac output state that we all know is a poor perfusion that also can be manifested by tachycardia, oliguria, delayed capillary refill, metabolic acidosis or hypotension, or low mixed venous oxygen saturations. This patient can normally have this in the first night with a peak at 12 hours after the operation. And also with the increase in troponin, and then we start to have these patients with manifest with the low cardiac output. We find the patient like no kidney urine output, arrhythmias, volume overload, pulmonary dysfunction secondary to this generalized edema, and renal dysfunction, and CNS sequelae. So this is also another very important graph. It's the same. This is the pulmonary vascular resistance and pulmonary vascular resistance and systemic vascular resistance, which increase maximally in the first 12 hours. This is with the lowest cardiac index here. And also the heart rate starts to increase at the beginning, then normalizes, then goes a little down. That's why also the atrioventricular pacing is very mandatory in the first, in almost neonates. Even if the patient is sinus is not used, the pacemaker atrioventricular pacing is not using for only heart blocks, because you know the trend of just putting pacemakers, just ventricular VVIs, is no more acceptable now. In all neonates, the best is to put atrioventricular pacing because you can control the tachycardia or the bradycardia by overdrive. Like it is a very important complications like for TOF or any surgery that affects the RV. The patient goes in jet. So this can be controlled by overdrive pacing, by atrioventricular pacing. So this is very important. This very graph is very important. This is a summary of increasing the systemic vascular resistance, pulmonary vascular resistance, at the same time with drop of the cardiac index after almost 12 hours That's why the first 24 hours of the patient post-operative is very, very important and very critical to all patients. This is a low cardiac output syndrome. Yes, Fadl.
Doctor, those two graphs, are they applicable to all pediatric cardiac surgery patients in general, or for specific groups like left-right shunts, or like
mainly for neonates, going bypass surgeries.
Okay.
You know, this is mainly for neonates and long bypass surgery. Okay.
Okay.
Like or any small babies, like a small tough, anything below the 5 kg. Okay. This is the pattern.
Okay,
this is a general pattern, increasing the vascular resistance due to the bypass effects on the lungs and also the systemic vascular resistance. Okay,
so
that's
what
why
I understood that the importance of those a couple of slides is highlighting the importance of following the patient carefully for the next 12 hours. Not,
exactly.
If he's okay for like 4 hours, 3 hours, usually we are comfortable, especially in adult cases. But here we have to be more cautious for longer time.
Exactly. This is very important. And I can tell you, I think in our center, we had a case like maybe 2 months back. It was a neonatal TOF. Everything was fine, went very well in OR and everything. But, you know, patient exactly, I think 10 o'clock, started to crash. And everything was fine. And this is only by induction of secretion, you know, there's some secretions with RT, and I think it was a junior nurse, and started to do suction and lavage of this stimulation increased the pulmonary vascular resistance. You know, the patient started to cough, and this increased pulmonary vascular resistance. All of this can tip the balance in any minute and makes the low cardiac output more manifest. And if it's not treated quickly, you might lose the patient, or might you go back to, like, you know, this is, as we said at the beginning, this is called an error, and can propagate an unintended state of cycles of errors that you might lose the patient. You know, it's like errors could happen everywhere, but you should predict it and how to, and usually the general rule in the ICU, you should predict and anticipate the error before it happens. That's why if you sit with the patient, and as you mentioned, is totally different than adults. Adult, if you have a good cardiac patient, CABG, done good, very good revascularization by good grafts, and patient good echo, and you tested your grafts, usually this patient will go for extubation with the nurse, no problem. Pediatrics, especially neonates, are different because they are liable to any minor changes in the circulation and circulation. And I can tell you, the pulmonary vascular resistance can, by suction or by any, or the patient awake because like insufficient sedation.
Any stressful condition.
Yeah, any stressful, especially sedation, not enough, or any suction, coughing. All of these things could result in significant increase in pulmonary vascular resistance or systemic vascular resistance that can increase this problem. Especially also if you, as we said before, like we can consider the residual lesions one of the errors. Like if you have suboptimal execution of task, when we said in errors, like for example, let's talk practically. You have a case, for example, a switch case, arterial switch operation. You have threats like the risk factors. Maybe a patient, when we say one of the threats is a morphology, like abnormal coronary, like you know, a demanding coronary, looping coronaries, or single coronary artery that needs more care. Then this is morphology issue. Comorbidities, maybe the patient is less than 2.5 or syndromic, like low birth weight. Then you have any problem in suboptimal execution of task. The coronary was not well mobilized, like some stretch on the coronaries. Then you have this patient in just balanced and in tropes. If anything that can cause, for example, increase in systemic vascular resistance, for example, like patient over volume overload, or patient like taking much vasopressors, then the patient, if anything can increase after load, this ventricle will strain. Then the coronary ischemia, if it is even 20% stretch, it will be more manifest, and you have the patient suddenly you have the patient going on low cardiac output, hypertension, and you might need ECMO, for example, you know, the patient might crash. So what I'm saying is, threats are there, errors could happen, but you have to be there. And also one of the tools that can make you, that's why we do it with the Toronto sick kids, they resembled by the flight plan errors, that you have to have a multiple check list, and also you have to revise everything. Like why we do TEE, like residual lesions. Like if you accept coming with moderate to severe residual lesions from OR, you should expect errors to propagate in the ICU. Yeah. Like for example, if you come with a case of AV canal, severe left AV valve regurgitation in the ICU, then any volume overload, the patient can cause with the patient can go like pulmonary edema kind of scenario in the ICU. Yeah. So accepting also accepting moderate to severe lesions in the ORs is also considered errors. And also we can also add this to judgmental errors, decision errors. Okay. Yeah. So, but in this picture, in this graph, we'll understood this one.
Yes,
Dr. Ahmed.
Tfaddal.
Doctor, I have one question regarding this graph. What I understand is this the expected course of every congenital cardiac surgery patient, especially the neonates.
Yes.
So let's say if I have a patient and his cardiac index started to deteriorate,
yes.
Regarding the management, should I just support him because this is expected and not look for a cause, or should I always actively look for a cause, even in an expected like decrease in cardiac index and increase in PVR?
Exactly. This is first of all, you have to support before, you know, like usually what we have in the ICU, the inotropes and the ventilatory support, the inotropes by all their types, and the ventilatory support, right? This is the thing that we have in the regular patients. And sometimes also the support can come by relieving, like for example, yes, what you have is the inotropes, okay? The inotropes and the vasodilators, you know, inotropes by all kinds, and the vasodilators. But during the support, you support and also look for the cause. Sometimes the pulmonary vascular resistance is increasing because the lung is really edematous and closing the chest is the problem. Then you have to open the chest. You know, you find the patient is really struggling with the ventilation. You have consistently very bad ABGs, but the heart by echo is good. It's fine, but the patient is desatting and you have a respiratory acidosis all the time, and the patient is not fine. And this will affect the cardiac output later on. So one of the support, either cardiac or respiratory, this is the fine tuning or the micromanagement at the level of the ICU. But generally, this all will fall in this category. Increase the SVR, increase PVR, and this is all can cause low cardiac output at the end. Like for example, I'll tell you one scenario. As we said, one of the things after long bypass, this capillary leak syndrome. Patient severe inflammatory response from the bypass, and as you all know, SIRS. Then the patient is still, you know, giving like severe edema from the everywhere, manifested by ascites, and also leading to increasing intra-abdominal pressure. The kidneys are starting to have acute renal failure, and also the lung is very bad. The lung is very bad because the myocardial, the interstitial edema in the lung because of the bypass. Then the fine tuning is different. You might think of putting PD cath, and also this is one of the routine now. We do most of the cases and also some centers, at least in our center, we do it in routine cases. In all neonates, we put a PD cath from the beginning, because the patient, once starting this capillary leak, you drain the abdomen, you give, because you know when the abdomen is full of fluids, it compresses the kidney less function, and also compresses the diaphragm up, also affecting the lung functions, respiratory functions. So once you drain, you have a PD cath, drain this one, release the abdomen, and also sometimes the affection on the lungs, you have to open the chest. And also some centers, they have low threshold, like our center also, to have, if the patient complex neonatal surgeries, we come out open chest. Also, because as I told you, if you see here in this one, everything almost normalizes after 24 hours. That's why we leave the patient open chest for 24 hours. Like if somebody asks you why you leave chest open in neonatal surgery, because the physiological effects on pulmonary vascular resistance and systemic vascular resistance on all units is getting high and highest after 12 hours and almost normalizes in 24 hours in most of the cases, if there's no other causes. So this is also an indication of open chest and PDCAT. So this graph normalized, well understood.
Yes.
Yeah, because I really want this is, I think the main one that I really want to have it to put printed in your mind, in having in all this is like an overview of all units in post-operative period. Yes, there is a lot of details. We can talk a lot about inotropes. We can talk about other management and everything. And everything is different. Like I'll tell you, for example, like you have a high pulmonary vascular resistance. For example, now you're having a case of truncus, or you have a case of which is well known. This case is coming with pulmonary hypertension, with the adding increased pulmonary vascular resistance after bypass. These patients come after surgery, the PVR is very high, then the RV is really struggling. Then one of the modalities to deal with this PVR, let's use pulmonary vasodilators, especially the nitric oxide. It makes a big difference in management and relaxes the pulmonary vascular bed, the PVR, relaxes the RV, and also can be used also in cases you know, this pulmonary hypertensive crisis, pulmonary, especially late AV canals. You know, patients are having high pulmonary, especially high pulmonary hypertension. Then these patients, they never have pulmonary crisis before operations. Whenever they have pulmonary crisis, the VCD and ASD are open, so can shift right to left shunts on some expense on desaturation, but still there is no cessation of circulation. But after you septate, you close the VCD and you close the ASD and you close the PDA, then this patient, when you have pulmonary vascular crisis, pulmonary hypertension crisis, due to this, it could be induced by any suction or any aggressive suction or anything, then when the pulmonary increases suddenly, the RV fails suddenly, then the patient might arrest. So one of the measures is to use pulmonary, this nitric oxide to prevent this crisis to happen, this one. And also some cases of expected pulmonary hypertensive crisis, some people, they come out of OR by pulmonary artery pressure lines to be continuous monitoring in very high risk cases. This is one of the modalities. I'm saying we're not going to go in details, in the little details of ICU management, but this is an overview of the whole thing. But we can give some scenarios. This is also the low cardiac output. See, again, this is the low cardiac output. The return is to baseline 18 to 24 hours after cross-clamp removal. It levels if levels of inotrope support and afterwards reduction are held constant. That's why is in high risk cases, try to be not to be like you don't need any dramatic surprises overnight. So you have to have, if the patient is stable first night, just keep everything stable. Try to have a reasonable cardiac index and keep the patient safe until the first 24 hours are passed. So that's why I told you, in the middle of the night, lowest cardiac index, highest SVR, highest PVR, the worst pulmonary function. So, and this should be returned back to normal in 24 hours. If you have any problem of all of this invasive support, like if you have any problem more than this patient, yeah, this is how the patient chest is open, left open, and this is the stent to make the chest sternum wide open to give space for the heart and also the lungs to move, because this myocardial edema, and I think all of you seen this with us, in the first day of night, the first, even after bypass, you feel the heart even bigger than the beginning and bulging from out the chest. Second day, when we do a chest closure, you find the heart back to normal size, and lungs are and lungs back to also normal. You know, the first night you find like hepatization, you know, this interstitial lung edema. And this is the pressure lines. This is most of the cases, high risk cases. We have two lines here. One of them is LA line, and one of them sometimes RV line or pulmonary artery pressure line. The LA line, as you all know, is like a Swan-Ganz in adult. This is put in the left atrial through the left atrial appendage or through the left atrial directly. This measures the LA pressure that reflects the LVEDP, and also reflects if the state of the myocardial functions, especially the left side. And the RV pressure or the pulmonary artery, this reflects the pulmonary artery pressure. As you see this patient coming out of bypass, the first night, see how puffy is the eyes. The eyes are puffy. This is the normal capillary leak syndrome that comes. And also this is very important. One of the management is the bypass, the fluid balance during bypass. And this is very, very important point. I think we're going to talk about it. If we can say what's the factor, the post-operative factors related to the severity and duration of the bypass. This is non-specific. As we said, this is the threats, risk factors, pre-existing status of the myocardium, duration of myocardial ischemia, duration of bypass. The patient procedure is specific. Any changes in the loading conditions. What does it mean, changing in the loading conditions? Like, for example, as you all know, I give you an example. Like left to right shunts, like AV canals or large VSDs. These patients come before bypass, preoperative, QPQS like 3:1, 2:1, 4:1. The LV is adjusted to high pulmonary blood flow. Return, the LV is adjusted to this volume overload. Usually they have no problem, but like just imagine a case of tetralogy fellow. Tetralogy fellow, QPQS is less than 1. The LV, because the severe PS, the severe pulmonary, the severe pulmonary stenosis makes usually it's very well known, the LV in TOF is very small because the pulmonary return is low, QPQS is less. These patients, like if you come out, if you do septation and you do close the VECD and you open the RVOT, you make the QPQS, usually you make it to 1:1. If you good septation and good pulmonary reconstruction, should be 1:1. But what if you have residual VECD in these cases? If you have residual VECD in TOF, it's completely different story, because these patients, you come out of bypass, especially if left to right shunt, QPQS to like 1.5 to or 1.7 or 2, if the VSD is big, the residual VSD in TOF, that means the LV that used to be small and receiving pulmonary blood flow low than normal, then you make it after bypass having more than normal. This is changes in loading condition. The patient might suffer. That's why residual VSD. Is it clear, this issue?
Yeah, he might go into pulmonary edema very easily.
Exactly. The LV, like this one, changing loading condition. The LV was adjusted, tolerating a very low pulmonary blood flow coming back to it. That's why it's a small LV. Then you make it after operation with the residual VSD is big, large VSD. That's why residual VSD is not well tolerated in TOF patients, but it's okay if AV canal or VSD can tolerate. So this patient, the meaning of changing loading conditions. Also myocardial incisions. If you have a patient with TOF and you do RVOT incision, big one, huge RVOT incision, this might cause arrhythmias, might cause dysfunctions. Also residual hemodynamic burden, expected or non-expected. Like if you have an AV canal case and you come out with severe left-sided AV valve regurgitation or any conduction system abnormalities, this also might cause the patient problem in the ICU. This is also very important slide, that the course in the ICU, the course is dependent on the whole story from preoperative. You should check the patient preoperative, how is the myocardial function, how's everything, and also you have to know in details everything happened in OR. You have to know the TEE, what's happening, the details. Everything could affect the course in the ICU. And also lesion-specific changes in loading conditions. There's a change in loads. Also the shunts, if you have the patient shunts, you know, like patients, for example, with decreased pulmonary blood flow, like patient with pulmonary atresia, small duct, then you put shunt, big shunt, then the patient is the same. It's also, you make a shunt patient. This is all volume overload to the ventricle, especially if there's a single ventricle, ventriculotomy. This is if it is large, it might affect the function. Coronary reimplantation, any issues, any stretch, any imperfection, any coronary implantation, you have bleeding postoperative, and you did secondary stitching blind after, it might also cause yes, you say, I did switch, everything is fine, reimplantation was good, but there was bleeding postoperative, and you take stitching from behind, you might affect the lumen, and also this is denervation in the transplant. So the special consideration units and congenital heart surgery, this is the same as we said. This is the patient, yes, the patient is different in units because increased capillary leak following the cardiopulmonary bypass, the transitional circulation of the units, organ immaturity, cardiac, renal, pulmonary, brain, and also decrease the nutritional reserve, immunocompromised, which are vulnerable for infections. This all can affect the longer stay, length of stay, and decrease the drug metabolism. So what happened in OR, this again could affect the post-operative acute volume loading or unloading of the ventricle, aortic suture lines, coronary manipulation, shunt placement, pulmonary hypertension in the OR. Any arrhythmias happen can cause effect. Also, what are the residual lesions? Post-operative TE is very important. Residual VSTs, residual outflow tract obstructions, heart block, tricuspid valve regurgitation, left AV valve regurgitation, stenosis. This all can affect the post-operative course. There are also hemostasis, generalized oozing, the bleeding. All of this can affect the course. And all of you know this bleeding, post-operative bleeding can cause a lot of problems that should be really dealt with immediately and optimally. Like, we are all like surgeons, we try to postpone reopening, and we should be really giving very good care. If you tell me this patient is really bleeding, more than 4 ml per kg per hour, and for 4 hours you should really, and the surgeon knows, this patient needs, but just giving, replacing, but at the end you might go in DIC, you have any problem tamponading. So this bleeding issue should really be taken seriously, and also not to be like, we are all surgeons have an inclination not to reopen quickly, but sometimes we really regret. We should take it, and also it's the opposite. Sometimes the ICU people, they just want to go and relax. They try to push you to open all cases. Also should be really a wise decision should be taken, the reopening for bleeding. This is also collective. Everything should be taken. Anesthetic regimen during surgery should be taken. The anatomic defect, cardiopulmonary bypass issues, details of preoperative and operative and residual lesions. All monitoring catheters is very important. Also, this is a very important slide. Also, does really fluid balance on bypass affect? Yeah, it really matters. And this is very important. This is how edema can affect everything, affect the oxygen delivery, affects everything. And this is a very important slide. They found out in patients, this is a very good study done in Children's Hospital in Philadelphia. They found out if you have the balance and in the fluid balance on bypass affects, they found the least mortality when you have this balance between -40 to -21 ml per kg for patient. Not to be too much negative and not to be positive. The more positive, if you have the patient positive, the mortality increases dramatically. So the best, also the fluid balance should be really calculated well. It's not easy, not on all centers as well. Only a professional perfusionist, they can know how to calculate, because it's not only perfusionists. The fluid balance should be calculated between the scrubbing nurses and the anesthesia and the perfusionist, putting all fluid taken in consideration, even the fluid that we use inside the surgical field, and also the fluid taken in the maintenance from anesthesia. So they give you, the balance should be all negative, a little negative, not too much negative, not this, the optimal one from -40 to -21 ml per kg to have a good optimal. And they found the more positive, the more increase of incidence of mortality, and also the more negative is not good. Because the best range is between -40 to 0 cc per kg, avoid too much negative, and also avoid too much positive, because it might affect the function of the myocardial function. So in summary, knowing the usual pattern of recovery, so that you can recognize what's different, know what happened in OR, help you to anticipate patient's recovery pattern. And this is the patient after, this is, as we said, open chest, and this is after good extubation, and see a completely different patient with chest closed and no more edema. So summary, know the patient's data, train the patient's data, know the expected pattern. If the course of recovery deviates from normal, should investigate it. Thank you.